Hello, my name is Emily Arnold, and for my CAM presentation, I chose aversion therapy. In this presentation, I'm going to be talking about the history of aversion therapy, indications for its use, contraindications, side effects and adverse effects, cultural considerations, and teaching outcomes. Aversion therapy is a treatment in which the patient is discouraged from a behavior being subjected to a punishing stimulus when he or she engages in that behavior. The purpose of aversion therapy is to decrease or stop certain behaviors by having a client associate unpleasant or painful experiences with doing the activity. There are a few different types of aversion therapy, one of them being olfactory gustatory stimuli, which uses repulsive smelling and tasting substances when the patient is conducting an undesirable behavior. Chemical stimuli can cause nausea or other unpleasant side effects when consuming alcohol, chewing nails, or licking and biting lips. Electric stimuli is the oldest and most known form of aversion therapy. Electric shock treatment has been used to treat behaviors, conditions, and tendencies for hundreds of years. It is also the most controversial therapy method. Electric aversion treatment uses a device to shock the patient every time they engage in negative behaviors. It began to be used in the 1930s to treat alcohol and drug-addicted patients. Later, it was extended to purely psychological conditions, such as homosexuality. Aversion therapy has a strong connection to discomfort, pain, and punishment, and for that reason began to fall out of favor in the 1970s. In 1973, the American Psychiatric Association removed homosexuality from the list of disorders in its Diagnostic and Statistical Manual of Mental Disorders. After this, aversion therapy began to be rejected as a valid approach to the treatment of homosexuality, although it still persists in certain isolated pockets of society. Its association with abusive treatment of homosexuality has especially led to its being discredited and rejected. Currently, aversion therapy is still used especially for drug and alcohol treatment and among certain behavioral specialists. Aversion therapy is an unpleasant experience by design, and such methods have often been judged to fall into the category of cruel or unusual punishment. Therefore, today it is usually based on the use of the imagination and the association of unpleasant images or memories with the undesirable behavior. This approach is called desensitization. There are many indications for the use of aversion therapy: nail biting, hair pulling disorders, OCD, compulsive eating and binge eating disorders, smoking tobacco or marijuana, gambling, alcohol addiction, pedophilia, and other types of bizarre sexual behaviors, violence, and atypical sexual identity behaviors. Patients with cardiac, pulmonary, or GI problems may experience a worsening of their symptoms, depending upon the characteristics and strength of the aversive stimuli. Some therapists have reported that patients undergoing aversion therapy, especially treatment that uses powerful chemical or pharmacological aversive stimuli, have become negative and aggressive. Most importantly, aversion therapy should never be used coercively. During the 20th century, when aversion therapy techniques were mentally and physically devastating to the patient, sometimes the consequences were disastrous, including fatalities, mental illness, and suicide. Today, adverse effects such as the following may occur: traumatic stress, clinical depression, disruptive emotions, cognitive task difficulties, such as problem solving or other abilities can be affected. Neglecting diet, exercise, medical treatment, or directions can also occur. From the 1950s to the 1980s, aversion therapy was a popular treatment choice for male homosexuality in the United Kingdom, which remained illegal until 1967, and entrapment by undercover policemen was routine until the 1960s. It was also considered an antisocial mental illness that could be cured with aversion therapy, which could also include giving patients electric shocks. It remained classifiable as a mental illness until 1990. In China, aversion therapy was also used as a means of curing homosexuality well into the 1990s. Homosexuality was, and still is in some cases, seen as unacceptable in Chinese culture. It is important to inform the patient that electric shock therapy includes mild electric shocks delivered to the forearm or leg. This approach should not be confused with electroconvulsive therapy that is delivered to the brain, typically for treatment of depression. Teach the patient to report any worsening of addictions, OCD behaviors, violence, or bizarre sexual behaviors promptly to the physician. Teach the patient and family member to report adverse reactions, such as a new or worsening depression, aggression, or decline in cognitive function. Use all forms of aversion therapy only as directed by a physician. In a research study completed in 2013, 15 nurses who had administered aversion therapy to homosexual individuals between 1930 and 1974 were interviewed and questioned about their opinions. In general, the majority of the nurses stated that they did not know what they were doing at the time, and that they were simply carrying out doctor's orders. One nurse stated, "I didn't ask why, I just did it. It was the doctor who needed to know the whys, what-ifs, and maybes in my day." Another responded with, "I didn't really understand what we were doing. None of us nurses did. I thought the doctor knows what he is doing, so it must be in the patient's best interests." These are the references that I used to complete my presentation. Thank you for watching.